5, Illegal Immigrant by Dr. Tephilah.
Good morning, everyone. I'll be presenting on behalf of Medicine 5, and the title of my presentation is Illegal Immigrants. Presenting Mr. A, he is a 47-year-old gentleman who is an LIC agent from Bihar. He presented with history of fever for 3 months, loss of weight and appetite for 3 months, and also myalgia. So the fever was high grade, intermittent, associated with chills and rigors, and was more at night. He had lost around 10 kgs of weight over the course of 3 months. There was no history to localize to any system. There was no history of cough, breathing difficulty, no burning micturition, no loose stools, vomiting, no headache, neck pain, altered sensorium. There was also no history of any transfusions in the past, bleeding manifestations or jaundice, no high-risk behavior, no history of any IV drug abuse. And he had no known comorbidities also. The only thing was 1 month prior to the onset of fever, he had developed left-sided chest pain. So when he went to the hospital, he was found to have an anterolateral STEMI. So this was his ECG that was taken. So PTCA was done and stent was placed in the left circumflex artery. Following this, after 35 days, he developed his first spike of fever. So he was evaluated extensively outside. So they had done a lot of blood tests and imaging. So his CRP outside was elevated. They had done workup for all infections, so viral, dengue, malaria, everything was negative. Urine routine was normal, but the blood culture reports are not available. They had also done imaging. So they had imaged the thorax, the abdomen, and also they've even done a PET CT, which did not pick up anything. Echo was done outside to rule out if there was any vegetations, and it only showed a regional wall motion abnormalities and an LVH. They had also done a bone marrow, which did not show anything. So over the course of 3 months, he was admitted twice, and he had received meropenem for 2 weeks. He had also received tigecycline, amikacin, and he also received ATT, following which he said he had transient improvement of symptoms. This ATT was given in December. So he presented to us in February, and on arrival, he was tachycardic. He had a pulse rate of 120 with a temperature of 103. And otherwise, only a pallor was present. There were no peripheral signs of infective endocarditis, aortic regurgitation, rheumatic heart disease, TB, or any malignancies. And cardiovascular systemic exam, and the fundus was also normal. The cardiovascular systemic examination, the first and the second heart sounds are heard normally. There were no murmurs, and the apex was in the normal area. It was in the fifth intercostal space, 1 centimeter medial to the mid-clavicular line. The other systemic examination also did not reveal anything significant. So summarizing, he is a 47-year-old gentleman who had come with history of high-grade intermittent fever with chills and rigors, as well as loss of appetite and weight for 3 months. And prior to this, he had a stent placed for a STEMI 1 month to this. And on examination, the only thing significant was pallor. So does anyone have any differentials?
The clue is if you have attended any previous clinical meetings. Case was presented by anyone. No answers. Huh? It's a PU. Some answers. What are the answers? Please read it.
Stent-related infections are most common. It's stent thrombosis, infective endocarditis, atypical microbacterial infection.
Okay. That's good.
Okay, so this is what we also considered. We considered infections, malignancies, and autoimmune disorders. So under infections, we considered infective endocarditis, stent-related infections, any occult abscesses, brucellosis, disseminated TB, and considering the region from his, we also considered histoplasmosis or HIV with opportunistic infections. Malignancies, we also considered lymphomas and other solid organ tumors that cause fever like HCC and RCC. And we also considered vasculitis and sarcoidosis on him. His initial blood investigation showed bicytopenia. So there's low HB and thrombocytopenia. There was an AKI and his electrolytes were also deranged and CRP was elevated. We had done workup to rule out infections as well as autoimmune disorders, which were negative, and bone marrow also did not reveal anything significant. We had done an echo to rule out vegetations, and what it showed was a small echogenic structure, which was suggestive of a vegetation in the aortic valve. It was present in the ventricular aspect of the non-coronary cusp. Infective endocarditis was high on our suspicion, and we had taken 5 blood cultures. So initially, the blood culture showed no growth. However, after 1 week, after 7 days, 2 of the blood cultures showed AFB in the smear. So our diagnosis at this point of time was mycobacterial infective endocarditis. It's probably due to an endovascular stent infections. And considering the time profile, it's probably a non-tuberculous mycobacteria, probably a rapid grower. So I would like to take 2 to 3 minutes to highlight what I've learned from this. So coming to Mycobacterium endocarditis. So it's a very rare cause of endocarditis. And the most common organism that is implicated is the rapid grower, which belongs to the non-tuberculous Mycobacterium type. So the problem with this is that it's very difficult to identify the pathogen, as well as it has poor sensitivity to the antibiotics that we give. So that makes this infection with a high mortality. So there's a Runyan's classification, which they've divided non-tuberculous mycobacteria into rapidly growing as well as slow growing. And the slow growing are further divided into photochromogens, cotochromogens, and non-photochromogens. So the important thing to note is that the rapid growing mycobacterium, they actually grow in the agar within 5 to 7 days of the blood culture. And the most common organisms are chelone and also fortutum in the rapid growing mycobacteria. So what are the risk factors to develop mycobacterium endocarditis? So the most important cause is cardiac surgery. So if there's any history of valve replacement, or if there's any septal patch repair, like an atrial or a ventricular patch repair, if there's any foreign material implant, like a pacemaker or a stent that is placed in a PTCA, like our patient, if the patient's on dialysis or IV drug users. So coming to stent-related infective endocarditis, it's a very rare complication of PTCA. So the only risk factor that is actually described is that if they reuse the angioplastic balloon catheters. What part of the heart is most affected is the aortic valve, followed by the mitral and the tricuspid valve. So in our patient also, his aortic valve was the one that was involved. And the mycobacterial strains that are most implicated are the rapid growing ones. So that is the highest on the list is chelone, followed by fortutum. So they all belong to the rapid growing mycobacteria. So I'd like to bring attention to our own Indian data. So this is a case series that was published in 2014. This basically they've taken 5 patients who had developed a stent mycobacterium infection post a stent. So out of which 4 patients were actually post a PTCA, and only 1 patient was post a stent that was placed for an abdominal aortic aneurysm. And out of which 4 out of the 5 had actually grown rapidly growing mycobacterium, and they had grown within around 2 to 3 months of the stent placement. So what are the treatment options we have? So if you see this data, the blue ones actually stand for patients who had developed this infection 2007, and the red, those which had who had developed infection 2012. So amikacin, linezolid, and clarithromycin are the drugs that are most used in this mycobacterial infection. So how do we actually treat it? So we empirically start with 2 or more of any of these drugs. So we use amikacin, clarithromycin, moxifloxacin, any of those drugs. And once we get a strain and once we get a drug sensitivity pattern, we switch over to the targeted management. So amikacin is supposed to be the most reliable agent. And clarithromycin is a drug which has its maximum effect on chelone, and moxifloxacin has its maximum effect on fortiotum. We can also, there are also surgical management. This we do in case we need to remove the foreign body material, like we can remove the stent, or if there is no improvement with medication, we can also, and the valve is damaged, we can do a valve replacement. So what is the prognosis of mycobacterium endocarditis? So if we see the case series, out of the 5 patients, all 4 of them had actually died even before stent was placed, or even before they died due to the infection. And the last patient was lost to follow-up. So coming back to our patient, we started the patient on moxifloxacin, clarithromycin, and linezolid. We were not able to start him on amikacin because of his renal failure. We have sent cultures in Kirshner's medium, so we are awaiting the speciation and sensitivity. We had also got cardiology and cardiothoracic surgery involved, and the plan is to continue antibiotic therapy. And in case there is no improvement of the symptoms on the sepsis, we may plan for a valve replacement. And we have also explained guarded prognosis to the family. So take-home messages, even though it's a very rare infection, if a patient who's post a stent replacement or any cardiovascular surgery and the patient has prolonged history of fever, it is rare, but we should also consider atypical mycobacterium infections. And we have also covered the treatment options, and also we need to know that it's a condition with poor outcomes.
Any questions from the audience?
So stent placement was actually placed 4 months earlier.
It was placed-
And then 3 months of fever, not 1 month.
35 days earlier.
The stent was placed 35 days before the fever.
Yes.
Why is that there no consideration for stent removal?
We had actually called cardiothoracic surgery and cardiology for stent removal, but they have right now said no need. They have, it has been done previously in these studies. I think there's one case report where there's a stent removal that was done, but when we got their opinion, they said no need. They said first start on antibiotics for 4 to 6 weeks, and then we would repeat an echo and then decide.
Because typically, at least with orthopedics, you won't get any clearing without removal of foreign body.
The other problem is because it's in the heart, it might be like all attached to the vessels and it might be difficult to remove.
I think so it's difficult. Second time by I think in the coronaries after embolization, it's very difficult to remove and also the height system. That's why we didn't want to introduce it. So, cardiology, cardiothoracic, and investigations will discuss the services.
How's he doing now?
He's actually sick. So he's developed thrombocytopenia, worsening AKI. So he's not doing too well.